Hi, I'm Dr. Jim Hoven, your host of the Difference Makers podcast. This is a place where people come together that are making a difference for those who want to make a difference. And that's you. We're bringing thought leaders together in a sense of fusion where ideas and concepts and personalities are all driven together into one place at one time. And this is no different. In this episode, you're going to see cool things from cool people making a difference. Hello, Difference Makers family. Your host of the show, Dr. Jim Hoven, here for the Difference Makers podcast. And today's a really special treat for me, and I think it's going to be for you, where if you've ever wondered about the topic of scoliosis, you may have heard about it, you may have experienced it, you may know someone with it, but it is something that is really, really technical of what happens to a spine. And I am with what I consider to be one of our nation's, if not our world's leading thought leaders in this. And this guy, he's a good friend of mine, so he's been sharing with me what he's been doing all along the road, and I couldn't wait to get him on because this, actually in June, is National Scoliosis Month. So no better time to have Dr. Chris Gubbles join us. And by the way, Dr. Chris was a guest of ours on the show, episode 118. Go check it out. You can hear more about his story there and his understanding of trauma and trauma accident-based care, that kind of thing. We went through that. So go check that out. But in this episode, we're focusing on scoliosis. So I don't want to waste another minute, not focus on me, but focus on him. So you're going to get great information. Once you hear this, share it with someone you know who has spine issues. And we are going to get going right now. So without further ado, Dr. Chris, welcome back.
Thank you. That was a pretty nice introduction. I might have to steal that for future needs.
Hey, you can have anything you want, my friend. Always glad to help you. Tell us, first of all, a little bit about what got you so interested in scoliosis. Actually, do this. Define scoliosis for us, and then tell us what got you into that, because you're super sports specific, you're super trauma specific, but this is your kind of ballywick, if you will.
Yeah. So technically, the definition of scoliosis is you have to have a lateral bend on your spine, like when viewing it on an X-ray, we call that a Cobb angle, and there also has to be a rotation, because scoliosis is technically the spine is rotating and it starts to deform, the spine starts to grow asymmetrical. So if you have a lateral bend of 10 degrees and there's rotation, that's basically the definition of scoliosis.
So just so we give a little background to people, if you're not familiar with spinal anatomy, basically you have your neck, which is called your cervical spine, your mid-back, which is called your thoracic spine, and the low back is called your lumbar spine. Yep. We've got 7 vertebra, 12 vertebra, and 5 vertebra. If we're looking at them from the front, they should be straight. To give orientation to people, this would be a front look where now there's a 10-degree curve in one of those things that should be straight from the front, but there's also rotation with it.
100%. And that's where a lot of times... if you see pictures of someone with scoliosis bending over, you may see like a rib humping or a hump on their low back on one side. That's because the spine is rotating, and that's what causes that.
I've seen that with patients in my past, and you and I were talking before the show, where this one beautiful lady, and she was when I was treating her, she was probably in her 70s at that time. So she had scoliosis throughout her life and tried to be braced and everything, but she did have this really large hump that threw her over and her kind of head tipping forward. And man, describe to people what scoliosis does to the physiology, some of the organ systems when it gets really severe, how it affects symptoms, that kind of thing.
Yeah, so the biggest thing as far as organ systems is when you get really severe curves, and that's typically in the thoracic spine, where it can impact, your lung function potential, cardiac function. And when that's when we're talking curves that tend to get over 80 degrees or greater, that's when those can be start to get involved. And that's where if a surgeon looks at someone when they're growing, if they have a pretty big curve and is a really high risk of getting worse, that's when they start recommending surgery, because they know where this could go. But it's generally only extreme cases that we look at real organ function loss.
Is there a reason or a known cause for scoliosis? Is it trauma-based? Is it what we would call idiopathic, where we don't know why? Like, why does the spine curve in some people like that?
So 80% of all cases are basically an idiopathic scoliosis, which means we don't know the exact cause. There's a lot of theories out there on what causes the spine to start to grow abnormally, but we can't say definitive like what causes most cases, but we really understand when it starts, how it develops, and how to manage and treat it. But then there's other 20% of cases that are caused by different things. You could have a trauma that causes scoliosis. You could have an underlying pathology like a tumor pressing on the spinal cord. You could have neurological conditions like someone with like a muscular dystrophy or something like that where they physically can't hold themselves up. And then there's even some like connective tissue causes like Marfan syndrome or Ehlers-Danlos syndrome, things like that. So the majority are an idiopathic cause, but then you have this other 20% that's kind of more the scarier causes that is underlying pathology that tends to lead to it.
And so before we dive any deeper, I've got so many questions just flooding my mind. Why scoliosis for you? What drove you for that to be your passion and you choose the path? Because now you've established this, basically this scoliosis-specific clinic alongside with your clinic and the scoliosis clinic called Scolicare that you're a part of with a group of extreme specialists in this case. How did you come to this passion?
Well, it's something I kind of fell into. So I was doing my training for chiropractic biophysics, which is an advanced chiropractic and rehab technique to really work on restoring the spine back to normal shape and alignment. But scoliosis, even within that, it's its own thing. And they had this new course coming out. They had never done it. And I went. I had no idea really what it was, but it was a pretty high-level course, and it was on where they really started introducing this method of doing custom bracing, following basically the ideas of like chiropractic biophysics, where it was different than hospital bracing, where in hospital bracing, they typically are trying to squeeze the spine and almost like a cast to hold it in there, versus the way that we are doing these braces, we're actually putting the spine in a correct position, or I would call a mirror image, to change how the spine grows over time. And that was my first introduction, and I realized right away I didn't know anything about scoliosis. I don't think anyone in the room did. We had very little knowledge. But it was a huge opportunity because we had patients coming. We didn't really know what to do. But that's kind of how it got started. And then it was just down a rabbit hole little by little. And then the floodgates opened up at one point.
Because you've done a ton of extra study and training in scoliosis, right? Give us a little insight into your specialty training.
Well, I remember I presented a case for my advanced certification for CBP. And then that case ended up getting accepted to present at, it was called SOSOR, which is the International Society for Scoliosis, Orthopedic and Rehabilitation Treatment, which is basically the highest level organization for non-surgical treatment. There's MDs, there's surgeons, PTs, and chiros. But I had a case that was accepted to present there. So I went over to France to present that case. While I was there, I met a group out of Italy called ISICO. It's basically the Italian group that does a lot of scoliosis over there. And I got invited to do a master's program, which is basically like a year-long program where they take the leading experts worldwide in different areas, and they were your instructors over like this, it was like 10 or 11 month course. And from there, I got more and more, and I got known to do it. And as things evolved, I mean, a lot of it, if you just keep showing up, opportunities unfold. So I just kept getting involved more and more, kept learning more training. And then the founder of the company that taught us to do the bracing, he developed his own clinics in Australia. And at one point he decided he was going to give doctors their opportunity to copy his model in a franchise. I think I was one of their first doctors they had talked to about this. And at the time I just converted my chiropractic office into medically integrated. I was very invested in that. And I didn't want to change all of that, but I got that to a point to run on its own. And there's a little bit different story why I actually started to do this. But then at some point I decided to open one of their clinics, and we are the first clinic in the United States that's open from scratch.
Wow. So now let's talk about kind of the clinic, the unique approach that Scolicare, that you guys at Scolicare do. So you might have a patient that comes from a medical doctor, or a chiropractor, or a physical therapist, because they're either not getting response or they have scoliosis and they're like, I can manage this, but I can't really help it. So they send you. What do those patients look like? And then what do you guys do?
Well, about 50% of our patients are direct referrals from other healthcare practitioners, chiropractors, MDs, PTs, for co-management, where we do the scoliosis part of the treatment, but they still remain their chiropractor or their PT. They're still their primary care doctor, but we just do the scoliosis part, and then we collaborate with the providers. But we have all kinds of patients that come in, and I think anything from, I have a 20-month-old infant right now with muscular dystrophy we're treating, all the way up to have an 88-year-old patient that's basically has a severe degenerative scoliosis. We have a wide scope, but in our clinic we do custom scoliosis bracing, and we're the only ones in the world that do bracing the way we do it. And the way we do it it helps ensure that every patient gets the perfect brace for their body. And I can tell you more about that in a bit. But and it depends on what we're trying to accomplish. Then we do scoliosis-specific rehab, which is basically physical therapy to teach the patient how to put themselves in a correct position, which is not easy to train. But then we show them how to strengthen and stabilize their spine in correction, and then incorporate that in their everyday life. So if you think about general physical therapy, you may go in and do some core stabilizing, which is fine. But our idea is like, well, let's learn and teach the patient how to put their spine in the maximal corrected position first, and then strengthen and stabilize and teach them how to make that more normal.
And that's got to be not only a musculoskeletal event, but a neurological event as
100%.
well, to get them to go,
Yeah.
wait, my body's used to being here. I got to think about it to go here, and then introduce dynamic movement, or at least stable movement through that.
Yeah, because patients come in, their brain thinks their body's straight. They don't realize they're crooked. So part of that, to really be considered a scoliosis-specific rehab, there's 4 requirements. One is an education. You're teaching the patient what's going on, because the more they understand what's happening to the body, they can understand what they have to do to correct it. But then you have to be able to teach them to put themselves in a 3-dimensional corrected position, because scoliosis is a 3-dimensional deformity. But then we incorporate their activities of daily living, so they learn to put themselves in correction while they do everything they do in their daily life. And then they're strengthening and stabilizing in correction. So it's really in-depth and highly skilled form of rehab, but very, very effective, and nothing else can get results like that in the rehab world when it's done and applied properly.
And so from that perspective, the typical treatments for scoliosis have been, you can manage it with regular traditional PT, which isn't really managing it like you just talked about. It's just it doesn't change the progression of the
It can be helpful. They can general chiropractic, general PT, yoga, massage, those things, that can be good for the patient. There's definitely lots of health benefits. It can relieve pain. We just know there's no evidence to support that those methods can do anything to influence the progression or potential correction of their curve.
And so on the nature of scoliosis, I think this goes to an age thing. You mentioned from 20 months to 88 years old. When does scoliosis stop progressing, and when does it have its most rapid progression? Like, is it related to hormones and age and all that stuff, and slow down with degeneration over time, or is it a consistent pathway, or does it fall off a cliff as it gets worse, then it just goes faster?
Potentially all above in some sense, but people think about first, it can actually develop at any point in your life. But most of the time, the reason that screenings are recommended is it's during that very beginning of puberty. It's called your peak growth velocity, when kids are rapidly growing, when curves can progress the fastest. Because if you have a idiopathic scoliosis in someone that has not reached skeletal maturity, the spine is actually growing deformed. Does that make sense?
Yes.
And what happens is you have growth plates on all your bones, and when you put pressure on a growth plate, it stunts the growth. So if you have a curve developing, the inside of that curve is going to have more pressure. So the inside of the spine will grow slower, the outside faster. And then what's interesting is it's when you hit puberty, before that, you have more growth in your legs and your limbs. But right about puberty, you actually grow faster in your spine. So you get these curves developing, and you take off and you grow as fast as you have your whole life. Like you grow as fast as you did the first years of your life, and that's when the curve can progress a lot. But we actually see a lot more scoliosis in adults. So about 5% of adolescents are diagnosed with scoliosis. When we get over the age of 60, it can be up to over 68% of adults
that meet the criteria of the 10 degree.
Yeah, there's been a couple of studies done on it, and like one, they looked at 75 random older adults that had no problems, just screened them, and they found 68% of those that were screened technically had by definition scoliosis. But if we look at how we age, at 40 years old, that's about 10% of the population. Once we hit 60, it's anywhere from upper 30s to at the extreme up to the upper 60s. And we know over 90, it's always 100% or 50% of the population. So we have a couple things going on. In adults, you have kids that they had scoliosis when they were younger, but it just wasn't picked up. that starts to become more painful, and they start to notice problems, and it starts to get caught around 40. But then right around 60, we think there's a bigger progression with possible hormonal changes, possible, because it's more common in women with the onset of menopause and, osteopenia and things like that, because that's when it really picks up. And then some adults develop it's called a de novo, a new scoliosis in adults, which is a degenerative problem. So in adults, when you're younger, the spine's growing asymmetrical. When you're an adult, gravity's pushing down and people lose the fight in gravity, and it's a degenerative process in adults. So it's two different things, but we see a lot more. And I think right now, like 90% of our cases are adults.
Wow.
That no one really knows what to do with these people.
And so when you talk about this, we had talked earlier about potentially what the more conservative approaches can be of managing maybe symptoms or pain, but not changing in the progression. Then there's the other end of the extreme on surgery when they put rods and those kinds of things in. Where does that come into play? And do you guys work with post-surgical cases?
We can. And so one point I'll say is the old watch and wait method, we would say, is not a form of treatment. You can do what's called observation, which is when you know when someone's developing a curve, but they're not yet big enough where maybe they need to do treatment, you're proactively doing regular check-ins, which is different than, well, you're fine, go home, and then let us know if anything changes, because that's where curves get really nasty when they hit those growth spurts. So you can do observation where you are actively doing regular checkups to see if it starts to progress. And then on the other end of the scope, there's surgery. And there is like measurements where someone becomes a surgical candidate. So typically in the thoracic spine, if the curve is over 50 degrees, in the lumbar spine, it's over 45 degrees. And there's always what's considered a scope of acceptable practices. So SOSORT, they have actually put guidelines together for different types of curves, different ages, what would be considered the minimal acceptable treatment and what would be the maximal acceptable treatment considered within acceptable ranges.
So I got to ask you this, since we both work with trauma cases, us here at the law firm and you at Square One at your chiropractic center, when someone with a scoliosis undergoes a trauma, whether it's a sports injury, a car accident, does that change the rapidness of how that spine reacts to that degenerative process, or does it depend?
You mean, are you asking that could it make the curve progress faster? Is that what you mean? Potentially, yeah. Trauma can always accelerate things. But even more so, we've had this happen in some cases where a patient had scoliosis, then they were in a crash where the insurance company said, hey, but this is related, their pain's from the scoliosis. But here's the thing, there's a lot of people that don't have pain or severe pain that have scoliosis. But you think about it, if you have scoliosis, you have a deformed spine, your spine's in a weakened state. So if you have trauma, we consider predisposed to a trauma impacting you more than if you had a perfectly healthy spine. And a way I like to explain this is, imagine if you took a linebacker for the Denver Broncos and he gets hit by a car, and you take a 90-year-old lady walking across the street and she gets hit by the same car, same speed. Who's it going to impact more?
Right.
So they're in a weakened state, and so they're predisposed more likely for trauma to impact them more than someone who has a perfectly healthy spine.
And so now if we don't take it to that extreme that we were just talking about, micro traumas with posture, with bending down and lifting things and all that kind of stuff, what kind of restrictions do typical scoliosis patients have once it's been identified they have it in their system? Are they restricted from collision sports like football or gymnastics or certain jobs?
Well, if you think about teenagers, a lot of times they don't have restrictions, but there can be things they're advised against. Because in teenagers, it's interesting, there are certain populations that have a much higher prevalence of scoliosis. So teenagers, it's thought between 3 to 5% have scoliosis on average. But if we look at particularly girls that are involved in competitive dance like ballet, and I don't mean like once a week. Generally, these are people that are doing this multiple hours a day, or rhythmic gymnastics. And even I've had some more recently that would kind of fall into that are involved in like competitive cheer and stuff. They have a 10 times higher likelihood of developing scoliosis. So those populations, the incidence is over 30.
So I wonder what is causing that. Do they have just a slight curve change, and then the constant bending and trauma and all these things of these activities at that age tend to worsen it, or like that just is interesting?
Well, a couple of things. So first, we can't say it causes that. We right now would say there's a correlation.
Yep.
But it is those populations tends to have much higher. One thing, it could be possibly because a lot of times they're thinner people. Sometimes they're more slender, so they could be less stable than someone who's shorter and stockier. Biomechanically, that could make sense. I've also seen in my clinic that a lot of times they have ligament laxity. So when I get a lot of these populations, you look at like their arches, they're almost always collapsed. So I think there could be some ligament laxity just in my own experience. But then also, and I've seen a lot of times they have a later onset of menarche too, like in like the girls. And so maybe there's something with a delayed onset of hormonal changes in puberty that could increase it. We can't say for sure, but we do know those are things that if we look at those, maybe they're not the best thing for them. But I get a lot of girls in that have those because it's a higher percent. And I guess my viewpoint is I don't want to take a child out of something that they love to do. I mean, I was a college athlete. So my viewpoint on that is I understand you love ballet or you love gymnastics. I'm not going to say don't do that, but this is also why you be compliant with your treatment so that you know the thing you love isn't harming your body like it potentially could if you weren't doing treatment like you should.
Wow. And would they do these, Dr. Chris, in a braced situation? Like, would they be braced when they would be doing the activity they love, or do they take it off and brace in between the performances?
So take it off. So if someone has an aggressive curve and they're wearing the brace full time, which is generally 20 to 23 hours a day, they take it off for activities, take it off for sports, they take it off, for showering and stuff like that. And I get asked like 23 hours a day. It's like, well, think about this. Every minute their body's in a crooked position, it's growing worse. And every minute we put them in a true corrected position where we're holding their spine in a correct position, their spine's growing more corrected, which is why we want to wear them as much as possible. Because we know that one of the things with bracing, I can make a perfect brace for someone, but if they don't wear it, it doesn't work. So dosage and how much they wear makes a difference. It's like imagine you give your kid braces or Invisalign, they can take those off, and they only wear it 6 hours a day. Well, you could imagine how effective that would be versus they're wearing it as prescribed all the time.
And so what about the change to the curve? This is something interesting that as I was thinking, when you're weight bearing, you're standing up, you've got gravity pushing down. Yeah. So now if the spine's going like this, it's kind of having an accordion type deal. Mm-hmm. When you lay down, is there any decompression of that? Because you mentioned wearing the brace up to 23 hours a day. So obviously you're going to be wearing it when you're lying down. Is that crucial for the spine not to grow with gravity too? So, and when someone's growing, and sometimes in smaller curves, they wear it part-time. Okay. And sometimes in some real small curves, they wear what's called a nighttime brace, which is a pretty aggressive brace, but they only wear it at night. But when we get curved beyond a certain point, we just know we need to be impacting that growth as much as we can. So they wear it all the time. But in adults, it's different because in adults, I always explain to patients what's happening is adults we're all in a tug of war with gravity. And as we age, we naturally start to lose a certain amount of muscle mass, so we get deconditioned, and gravity starts to win. So as adults, gravity's pushing down, and the spine starts to break down. People can't hold their spine up, and they start to get twisted, and they start to get that forward, like hunch and lean too. So at night, they do decompress. So in adults, we don't generally recommend wearing bracing at night unless they have a lot of pain and they can't sleep and it gives them relief. It's when they're upright that it's effective. And there was a really cool study and if you ask any orthopedic doctors or pain management doctors, they never even think about like bracing for adults with scoliosis is a completely different concept. But it was a really cool, like a landmark study that came out, and they looked at a population of adults that had scoliosis, and they just observed them over 10 years. They kind of looked at them retrospectively, and they found the average adult with a degenerative scoliosis got around 1.5 degrees worse per year. So over 10 years, they got 15 degrees worse. And that's a big deal because we also know the size and severity of the curve is directly correlated to the severity of potential pain. But then they had them wear these lower profile, they were generally like lumbar scoliosis, lower profile custom-made braces, which are different than the brace you just wrap around and squeeze you. And they had them wear it 4 to 6 hours a day when they're upright, and they slowed the progression down to 0.1 to 0.2 degrees worse per year. So think about over 10 years, 15 degrees worse versus 1 or 2 degrees, and a lot of curves actually got better. Wow. So it's like game changer because no one knows. Most people don't know what to do for these cases. You could do injections, or you can do facet blocks or epidural injections. You can do pain management, but those things may make them feel better for a little bit. They don't do anything to impact the curve. So it's literally a game changer for the right patient. Yeah. And when you talk about curves, you mentioned lumbar spine, which as we talked about before is the low back. Thoracic spine is the mid back. Do we see a lot of scoliotic curves in the cervical spine where it bends this way, or are those typically straighter, and then you start noticing things in the thoracic and lumbar spine?
We do get some, and they're hard to treat.
Imagine they're real hard to brace too.
Very hard. We can do an extension on a brace that holds the head over. Not real fun to wear. But the other thing, when you get in the upper thoracic spine, you have your shoulders and clavicle, you get anatomy in the way. But the majority of cases are in the lumbar, the thoracolumbar, and the thoracic spine. And then in adults, it's generally the curves in the lumbar spine and the thoracolumbar that are more progressive, because you don't have like the rib cage and the bony structure supporting you. So those are the ones that we see more common a problem. But you can have a progressive curve in your thoracic spine if it's big enough.
And so when these curves happen, you talked about this a little bit earlier, management becomes key. So I imagine, I know even when I was, young in practice, we would do scoliosis screenings. We would go to schools and we would just put our hands on shoulders and hips and, get little measurements. And then we moved to a digital program that we could kind of take a picture and then it would make a
Absolutely.
thing. Is that still what is recommended as the gold standard of care, to screen first and then treat at a certain level?
It's a really good question, because it used to be there was mandatory scoliosis screenings, but then a while back they were canceled because they thought there was too many false positives in the screening. And basically when you're doing a screening, you're looking for potential rib humping or signs of scoliosis. And if you think someone may have scoliosis, you get an x-ray to rule in or rule out scoliosis. So they thought there was too many, adolescents that were x-rayed and found that they didn't have scoliosis. But big deal. I mean, that's a good thing. It's like, you may have scoliosis. Oh, you actually don't? Like, great. But the bigger thing is to not screen and miss those that need the treatment. It's a bigger thing. So it's starting to be reversed in the scientific world. There's just not a change in some of the programs that have been done. And a lot of times the person screening is not real skilled at it. But the Scoliosis Research Society came out with recently a position statement where they said we absolutely need to be screening adolescents, because earlier detection leads to earlier and better treatment and better outcomes, because all big curves start off as small curves. And so girls are recommended to be screened at the ages of 10 and again 12, because that's generally when they start to hit their growth spurts, and boys between the ages of 13 and 14. But the reality is these aren't done. And so we have some videos where we tell parents what to look for, which if you're a parent, this is a great time to look for some asymmetries, because in the winter, kids are wearing hoodies and sweatshirts, but now that they're wearing bathing suits and boys don't have their shirts on, perfect time is where we see a lot of times the parents start to notice things. So we don't have, like in Colorado, a screening program for the state, but it is recommended. It's also one of the reasons that we'll do free screenings in our clinics, because parents may say, can you just check my child to see?
So let's dive into that for a second, Dr. Chris. If someone's watching this that has a child in that 9 up range, or now they're past that, now they're in high school and they've never been checked, what things could they look at as landmarks and then give them that, like you call it, the red flag to say, ooh, maybe I better go talk to someone? So,
and really at any age, because we do get juveniles, a juvenile is anyone between 3 and 10 years old. And if they have scoliosis when they're younger, they have a high risk of progression. But look for asymmetry. So do you notice one shoulder is higher than the other when you look at them or in pictures?
Kind of from the front.
From the front or the back, yeah. Is their shoulders unlevel? If you look at them from the back, does one of their shoulder blades stick out? That's called scapular winging. Do you see a shoulder blades? They not look even or symmetrical. If they bend over, do you see a humping on the ribs, which you'll see in the thoracic spine? Or in the lower back, do you see a hump there? Do you see like a asymmetry in their waist? Does one side of their waist look flatter and one look more indented? Do you think that their legs appear to be different lengths? Or just like, is there anything that doesn't seem the same on both sides almost? Those are like, hey, there could be something going on. And so it's good to check your kids. And we actually have an app that kind of guides parents through. I can give you guys the link, and it kind of walks parents through like what to look for, and it gives them the risk of progression.
What's the name of the app? And then we'll link it for sure.
God, I knew you were going to ask me that. I think it's called Scoli Check, something like that. I'll look here in a minute,
we'll get it over.
Put it in the
show notes.
Yep. And then those are things to really look for.
Okay. And is there any functional stuff, Dr. Chris, that would we know that if they can, let's say they go like this, they put their hands together and one goes way farther than another, or if they were to bend forward or reach, or is there any functional things?
So when they're looking for that humping I was talking about, the idea is you put their hands together like they're praying and have them bend forward, and then look at them from behind and you look and see, do you see a hump on one side or the low side? And remind me, I'll send you guys some images. You could probably put it in the video of kind of
Great.
schematics of what to look for.
Yeah, that's perfect.
Yeah.
Okay. So now you're talking, this is what you're doing with people. We mentioned the surgery earlier and I missed it. Do you guys do post-surgical work with folks?
We can do pre-surgical, because pre-surgical is we get cases that need surgery. But if we can get their spine in a healthier position, if we can get their spine stronger and more flexible before surgery, they have a higher chance of having a better post-surgical outcome. And then after surgery, we can do post-rehab to strengthen and rehabilitate their bodies to support and strengthen and stabilize afterwards. So we can do all of that.
Okay. And is there a point in time that determines when surgery is necessary? Is it a pain thing? Is it a numbers thing on the curve? Or how do you know when it goes there? Or is it individual?
Yeah, so as a child, it's generally, like I said, there's in the low back, 45, in the upper and mid back, 50. That's when someone hits a surgical threshold. But just because someone has met that threshold doesn't mean they have to do surgery, but they're a candidate. They can still do non-surgical options. We had a study that just came out by Dr. Tony Nalda down in outside of Orlando, Florida, where we had a series of surgical cases that were in the mid-50s that got reduced all the way down into the 30s, doing a traction like we do in CBP, combined with what we do our scoliosis rehab called Scoli balance and bracing. So there are instances where someone has been at a surgical threshold, they still can respond to non-surgical treatment. But then we get to the point at some cases where they get beyond the point where we have evidence to support that non-surgical care can work. But if a patient can still say, I get it, I still reject surgery. And in those cases, we can have to a certain extent, they can sign a waiver where we're saying, we don't have evidence to show this can help you. But if you want to give it a try and you're refusing surgery, in some of those cases, we can still work with them.
Wow. That's really cool that they have that option. You know, as you were just sharing that, something popped into my mind that was basically that I had never thought of before with respect to scoliosis, and that's the effect or combination of scoliosis with osteoporosis. So normally our bones get denser as we get older with osteoarthritis and degeneration, all that stuff happens. But in osteoporosis, our bones get thinner. So is there an increased compression fracture that occurs with that?
Yeah, and a lot of that in adults is also due to kyphosis, because we do kyphosis treatment too. That's where they start. Kyphosis is when you hunch forward and you get an increased curve in your mid back.
That's what I have, by the way. I have big kyphosis.
So, and I had a privilege at one of the CBP annual research conferences. They had the head researcher on women with osteoporosis and kyphosis present to us, and it's a big problem, because if someone the bones get thinner and they hunch forward more, you put more pressure on the anterior part of the vertebrae, you're at an increased risk of compression fracture. And those we know 100% there is correlation with cardiovascular and cardiopulmonary events. And actually, we know if you have two people, everything is the same, say blood panels, everything else is the same. One adult's hunched over, the other one that is not. The adult that's hunched over has a 2.4 greater likelihood of having a cardiovascular event.
2.4 what? Times?
Yes. More than double. But we also know in adults, when they hunch forward or they get scoliosis, they have an increased risk of falls and fractures. Because one of the things you look at is what's called get up and go. So when we see patients, before we do any rehab, we do what's called a functional analysis. So our rehab therapists, they will measure where they're strong, where they're weak. They'll measure balance for the right people. And we want to see if they're at risk of falling, because we will rehabilitate them in correction and we will strengthen their weak areas, because what it really comes down to is how functional are you in life? Because when you're an adult, a lot of times our goal is not to straighten the curve. But let's say you had scoliosis and I told you, our goal is not to straighten your curve. Maybe we can improve it, but that's not the goal. But if we can get you out of pain or in much less pain, if we can stop or dramatically slow the progression, and we can get you to the point where you can do the things that you love the most as long as possible, is that an acceptable outcome? And they're like 100%. Because when you get older, people really want is they want to do the things they love as long as possible.
Yes.
That's what matters.
Yes. And so I'm super intrigued, because again, I have a really hyperkyphotic spine. And so that is something I've never thought of in the scoliosis realm. And of course it's a curve change, but they were kind of different diagnosis in my mind. I think that opens up a whole new conversation for you to have with folks about saying, look, it's not just if your spine goes this way, but if it goes that way.
And when you look at adults, there's something called an anterior sagittal balance. So from the side, your body should be balanced. That's when you're the most efficient. And if your upper back starts to lean forward and you go forward, especially when that gets beyond 40 millimeters or 4 centimeters, that's a huge predictor of back pain and disability. It's actually the number one predictor of disability from back pain is when people get really hunched forward and their upper body is translated forward from their pelvis, because it's basically a lever arm and their back has to work so hard to hold themselves up. So now we developed a new brace. It's called a sagittal balance brace, where we do bracing for adults just because they're starting to hunch forward and collapse forward, and it literally supports them. And Dr. McAvini, who's the founder of Scolicare, he'll explain to patients, like, you need scaffolding, you need something to support you. You can do that with rods on the inside, or we can do with a custom brace that doesn't let your spine collapse against gravity. And that is like, and people love them because their body gets relief, they don't collapse throughout the day, their muscles get to recover, and they just feel much better.
And when your patients are wearing these braces, are they on the outside of clothes? Are they under clothes? How does that work?
They always wear an undershirt. They get some with them, but we don't want them to put it right in the skin to keep the brace just from a hygiene standpoint.
Yes.
But they can do either, because a lot of times patients we can't even tell they're wearing it. Like, we just did an open house and I had one of my patients who is a great patient. He's a college student and he had a big curves over 50 degrees, and he did our rehab and he came to our open house. And I was like, oh, you should have wore your brace. And he's like, I have it on. I couldn't tell he had it on.
Really?
And he's actually really cool because he was looking at becoming a physical therapist, or he's looking at becoming a chiropractor. But then you were like this. He said, I've actually decided I'm going to go be a DO, but I want to specialize in this. And I said, well, if you be a DO and you work in scoliosis, I'll teach you how to adjust.
No, that's great. I love that so much. So kind of as we wrap this down, when people are wearing bracing, is bracing something that is, once you get it, and I know the answer would be if you go from a child to an adult, the bracing is going to change, just like orthotics, right? Yep. When we would do orthotics for patients, if we get them as kids, we have to, as their feet grow, we got to get them new stabilizing devices. But what about with this kind of thing? As you get better, do you get a new brace that holds you now in a different position, or you're there and that's the only brace you need?
Well, when children are growing, they can outgrow the brace, so the brace is not pushing on the correct spots anymore because their spine gets bigger, so they may need a second brace. But adults generally get one brace because we can do modifications. We have a workshop in our clinic that I can change and modify a brace like an orthotist out there. And I think you were going to ask us, do they have to wear them all the time? Yes. Too? And it's case by case. If we get someone that is really severe and hunched over, they're probably going to wear their brace a few hours a day just because it holds them up. But a lot of adults, if they're really good with their Scoli balance, we call it like the rehab, they can get to the point where they can decide if they want to wear the brace or not, because we do periodic checkups. We can tell if it gets worse. And one thing I want to say is, as a myth that I hear all the time, is that braces cause atrophy. And that's when people say that, is because they don't understand what we're doing. And Scolicare just came out with a study where they evaluated patients that were teenagers wearing brace full time and doing scoliosis-specific rehab, or Scoli balance, and they measured trunk muscle endurance and erector muscles. So basically your trunk muscle strength and endurance before, and then at short and long-term outcomes. And 100% of the kids, not only did they not get atrophy, they increased across all parameters for muscle strength and endurance. So when done properly, you don't have to worry about this muscle atrophy. So if someone says that, they either are talking about some other kind of brace, or they don't understand what we're doing and how these braces work. And
I think the key to that, probably from my perspective, is if you're part of a team like you guys have at Scolicare, now you're getting the entirety, the 360 degree scope of it is what I would call it, because you're getting the brace to support you, but then you're getting the underlying rehab to protect you so that you don't have to wear it as long, and you're getting the serial evaluations to monitor you so 100%. That you know that you're not guessing anything. I think when bracing gets to be a problem is when people rely on it as a crutch and they don't incorporate those other components.
I mean, absolutely. And so Scolicare is doing something no one else in the world is doing. They are taking the top scoliosis therapists in the world from the physical therapy background. They're using people that are specialists in biomechanics, typically chiropractors and bracing, and they're combining them as a team. And no one else is really doing that at this level in the world, which is very unique. And the other thing about when you mentioned that, one of the things with bracing done at a lot of hospitals, the one that we do at Children's Hospital, they work using what's called 3 points of pressure, where they're trying to squeeze the spine. And they're not even trying to correct it. They're just trying to squeeze it, where we're actually putting the spine in a correct position. And Scolicare just did a study comparing our brace to theirs head to head. And there was a study done not too long ago, which was a landmark study where they found using what's called the Boston brace, using at Children's Hospital, They were just looking to see if they could reduce the risk of progression to surgical levels. They weren't even monitoring to see if the curves got better. And they had a 72% reduction in going to surgery. We just had a study out that we had 87% of those did not reduce to surgery. Nobody got greater than 50 degrees. These were already big, aggressive curves too. And the majority of people had a reduction in the curve, which no one else even generally looks at that.
Wow. And so tell me the difference between a brace that's, so you have a curve going this way. So I'm picturing the typical traditional brace trying to squeeze that so that you make a bent spine straight. What does your Scoli brace do?
Two things. One, they're not custom made. They can use some of the same software that we use electronically to get the size, but they're more like tube. They're trying to squeeze the spine. And the other problem is they have an orthotist that uses his own arts and crafts skills, so to say, to make the brace. So it really depends on how good he is. And a lot of times you have an orthotist who is trained at doing a lot of orthotics, but maybe not real skilled at scoliosis. So if you went to 10 children's hospital with your child, you're probably going to get 10 different braces. Where we take that out of the equation and we use software to gather the data, we send it to an engineer in Sydney, Australia, and we custom make the brace. And so if I had 10 doctors doing what I'm doing, we know all 10 of those patients are going to get the exact perfect brace, because it's not my hands that have to build it. I have to gather the data and figure out what we want to do, but then the engineer will design it to get the perfect brace for that patient. But our braces take the spine and they untwist and unwind. And if it's a younger person that's more flexible, we'll actually put them in an opposite position. In an adult, we're more stabilizing, but we're putting forces that work to untwist and unwind the spine versus just trying to squeeze it. And that's the big difference.
So does that mean there's, like when I used to give patients what was called LO631 braces, it was just a code, but it was a specific brace for low back folks. And we would take it and we would have them draw it up in an up and outward way, and it would act like a girdle and it would squeeze the spine up. Is there any of that when you talk about this brace that you can kind of untorque the spine? Because I picture a lifting
the brace does it. The way the brace is designed asymmetrical, the brace does that. Oh. So when they put the brace on, like we can look at someone and take an x-ray of them, we can put them in the brace and you will see the spine do this. We've even started measuring patients because you'll see them get taller with the brace on because it's unwinding versus when you twist, it goes like this. So the brace does that work, but then we also teach them how to do that with the rehab. We actually teach them how to de-rotate their body and put it in a correct position, which is not super easy. So you have to have someone that's really skilled and trained to do this.
Man, you can tell I'm getting all geeked out about this. One more question. I promise I won't keep you here forever. When and someone starts going forward or tilting, if Wolff's Law is coming into play, we don't have we don't have the osteoporosis. Let's say everything's pretty good there. Wolff's Law, the thing starts going down, and that way, do you lose the ability then to come up and back out because Wolff's Law has reconstructed the bone in that way, where we can't get a lot of back upright for a hyperkyphotic or a rotated spine?
So potentially, yes. So like in a younger adult that's still flexible, sometimes we can still get improvements and change in their spine. And if they're like really shifted over, we can actually correct that. But when someone gets really old or they get severe degeneration on one side of the spine, then a lot of times you're not going to see very much change, if any at all, but the goal is to stabilize. But those people can still get tremendous relief.
Yes. Oh, so good, man. This has been such a great conversation. I need for you to share how people can get a hold of you to learn more about this amazing concept, because it's new to me. It blew my mind when you first shared it with me, and I knew we just had to get it out there. So if people want to know more about scoliosis, or they know someone or have scoliosis and want to talk to you and your team, what would they do?
So our clinic in Denver is just Scolicare Denver. You can find us on any social media, but also on my personal profiles, that's all I do is post on Scoliosis and Kyphosis, which is the Scoliosis Doc on Instagram, or just Chris Gubbles on Facebook. You can contact me there too, because I use that because all my friends are professionals and I'm educating just by those platforms as well.
Man, that is so great. Chris, this has been such a great show. Thank you for coming in. For those of you that heard this, if it didn't make sense a little bit, if it was just a little bit technical, that's okay. Listen to it again, or better yet, call Dr. Chris and he'll be able to walk you through it, because the first time you hear anything new, it's new. So it's going to take a little bit of time, but this was, trust me, fantastic, instructive information that's going to guide you and people that you know with scoliosis. So reach out to Dr. Chris at Scolicare. Also, please, if you're watching this, there's a little bell icon that you can hit. If you hit that, that's going to, the next time we send you something, you're going to be able to, the first to be able to see it. So check that out. subscribe, do all the social media things that you would do. Please, if you're listening to this, we want to make a difference just like you're making a difference. And the only way that happens is if you'll share this with others. So there's going to be show notes with all of these different connections to the things Dr. Chris talked about. We would look to get some pictures and other things from him in here too. But if there's any other things that you would like us to talk about, we have an open forum here. So you can email me, jim@ramoslaw.com. Send me a topic, send me a potential guest, and we'll see if we can get them on. And we can share information like this because everyone is here to make a difference. Everyone. And these people like Dr. Chris and our other guests, they're making a difference. And at the end of the day, that's what we want for you too. So until next time, get out there and make a difference.